Welcome to this e-lecture on the pain pathway. It will be in two parts. And the reason we're doing it is because pain is such a common symptom in so many different conditions that really it warrants a topic in its own right. So we're going to look at it in general terms. When we look at different conditions, different anatomical systems, then we'll look at specific aspects of pain related to that system. But underlying it all, the pain pathway is common to everything. So this is a two-part e-lecture. It's designed really to underpin things that we're going to go over when we get into the actual talk component of the module. So in terms of the e-lecture, what we're going to do is we're going to try and define pain. We're going to talk about the factors that contribute to it, but we're also going to look at three categories of pain. So that's nociceptive pain, which involves the detailed pain pathway. We'll link that into nociceptive pain. Eventually we'll talk about inflammatory pain as well, and in passing we'll talk about neuropathic pain. In part two is really going to be about alterations to the pain pathway. So we're going to talk about referred pain, modulation of pain or inhibition of pain, and on the flip side really we're going to talk about sensitization and long-term potentiation of pain. And this really links back into inflammatory pain. An unpleasant sensory and emotional experience. The implication here is that there are very strong links between the physical stimulation of pain and the higher centres of the brain, particularly the limbic system. Emotional responses to pain may be affected by our previous experiences or our beliefs about what a specific pain may mean. Note the next bit, associated with actual or potential tissue damage. This tells us that nociceptors, pain receptors, can be stimulated in the absence of actual physical damage. And what about or described in terms of such damage? What does this tell us? It doesn't matter whether the pain is there or not. If someone says they are in pain, they are. The pain scales we use, if naught equals no pain, da-di-da-di-da, are all about the patient's subjective experience. In other words, pain is a complex mix of factors that are interdependent upon each other. Acute pain is protective. Okay, so let's think about acute pain. You put your hand on a hot plate or tread on something sharp, you immediately activate the withdrawal reflex, which being a reflex and not involving the cortex, is pretty quick. And this limits the amount of injury. In terms of internal pain, involving organs, muscles, joints, you may change your behaviour to prevent it happening again and rest the affected part to allow it to heal. Chronic pain, on the other hand, involves the physical sensitization of nociceptors and synapses, combined with long-term psychological or behavioural changes. It can present as a disease in its own. The three main categories of pain are not necessarily standalone. There can be a combination of nociceptive pain. Remember nociceptors? Free nerve endings covered in receptors that can detect noxious chemical, mechanical or thermal stimuli. They then transmit it via an action potential along afferent neurons to the sensory cortex. Neuropathic pain is where the neurons themselves are the source of the pain due to injury or disease. Inflammatory pain is related to the sensitization of peripheral nociceptors or central synapses, and we're going to discuss this more in part 2. So nociceptive pain is about the stimulation of nociceptors by something noxious or harmful. The noxious stimulus could be thermal, mechanical, or chemical. It's detected by receptors that open ion channels, creating excitatory graded potentials. Remember EPSPs? Most of these channels are categorized as transient receptor potential, or TRP channels. In other words, they cause transient or graded potentials.
Let's look at an overview of the pain pathway. We have looked at it before in physiology, but we're going to look at it again, perhaps with a slightly bit more detail. So this is where Nikki gets her magic pens out. So, we always start, and it's always good to think about it in terms of where the pain starts. And remember, this is an afferent pathway. So we're going into the brain. So we start at the nociceptors themselves. So you remember we had nociceptors as those free nerve endings. Then we have a trigger zone. The trigger zone, of course, is full of voltage-gated sodium channels because it's just like the axon hillock. Of course, in afferent neurons, sensory neurons, there'd be no point in having the trigger zone up by the soma because the soma is miles away. So you remember where the soma is. So we have our primary afferent, goes all the way up. The soma is up in the dorsal root ganglion. From the dorsal root ganglion, we go into the dorsal horn. So here's our dorsal horn. Nikki's rubbish equivalent of the dorsal horn. Yes? In the dorsal horn, our primary afferent, then synapses. And we'll go beyond that in a minute. So our soma, if you remember, is in the dorsal root ganglion. This area here, we're talking about something called transduction. This is where the pain stimulus is. So on our little free nerve endings, what we have is, we have all these little receptors called transient receptor potential receptors, and we have their adjacent channels. Those channels could be sodium, they could be calcium, but we get an influx of cations. So we have little channels that can open. And of course, when they open, we get an influx of calcium or sodium. If we get an influx of calcium or sodium here, you remember what we get? Yeah, we get an EPSP. And you remember what our axon hillock did when we talked about it before? It summates those EPSPs and it generates an action potential. If threshold is reached here, we generate an action potential. In the primary afferent, that action potential is going to go along, up into the soma, back out again, and ultimately into the dorsal horn. Okay, at the dorsal horn, what are we going to get? We're going to get another EPSP, and we're going to get a synapse So chemical transmission across that synapse to the second order afferent. The second order afferent, if you remember, crosses to the other side. Do you remember that great word? Decussates. Crosses to the contralateral side. And it then goes up the spinothalamic tract. If you remember, the tracts are a bit like nerves in the central nervous system. They're pathways. So our neuron, our second order afferent neuron, is going to ascend through that up. And where does it get to? It gets to the thalamus. The thalamus, if you remember, is like a precortical relay point. So at the thalamus, we have another synapse. So this is at our thalamus. The thalamus is embedded within the limbic system, and this will become important later. We'll talk about this later. From the thalamus and this synapse, we go on to the sensory cortex. Yes? At the sensory cortex, you remember that slice? We had the motor cortex, and then we had the sensory cortex, 2 slices down the brain. This goes on to the sensory cortex. Now, you remember we talked about this as transduction. So down here is transduction. This passage of our action potential through the primary afferent, across the synapse, through the second order, up the spinothalamic tract to the thalamus, another synapse, up the tertiary or third order afferent to the sensory cortex, is transmission. So we have transduction, transmission, and at the sensory cortex, we have perception. This is where we perceive that action potential as pain.
Nociceptors are free nerve endings and are found in skin, muscle, connective tissue, blood vessels, and the organs. Basically, just about everywhere. These free nerve endings are covered in receptors that open cation channels, creating local areas of depolarization, i.e. EPSPs. The receptors all respond to different stimuli, such as noxious heat or cold, noxious mechanical events, or chemicals such as inflammatory mediators or protons. Okay, so here are some TRPs. You don't need to remember them all, but you do need to be aware that different TRPs are stimulated by different things. Right at the top, TRPV1 was the first to be identified, and it's still often used in research because it binds and responds to capsaicin. Capsaicin is a component of chilies, and it's the reason you get that burning sensation whenever you chop chilies and then you rub your eye or you rub anywhere else. In addition to TRP channels, there's a couple of others. ATP and adenosine may be released from cells under certain conditions. They can then bind to purinergic receptors to transduce or cause pain. The receptors are either G protein coupled, metabotropic receptors, or they're ionotropic receptors on cation channels. Acid sensing channels, ASICs, bind protons, generally in acidosis. They allow an influx of sodium and calcium to cause pain or transduce pain. We'll come back to these when we talk about ischemia during the module. Basically though, whatever the channel or stimulus, an influx of cations creates an EPSP. This is then summated at the trigger zone. The trigger zone is exactly like the axon hillock we talked about before. If there are enough EPSPs, it will generate an action potential.
Okay, so let's talk about transduction in a little bit more detail. So far, yeah, we've got free nerve endings, nice spidery fingers, but we're going to look at them more in terms of what the channels are. So, okay, you remember transduction basically ends with our trigger zone, our axon hillock equivalent that's full of, what's it full of? It's full of voltage-gated sodium channels. So we need some voltage sensors. Here's our voltage sensors. If you remember, just like the axon hillock, they have a threshold. They reach threshold when there is a predominance of EPSPs, either through temporal or spatial summation. When they open, what we get is a flood, don't we, of sodium into the axon of the neuron. When we get the flood of the sodium into the axon of the neuron, what happens is that sodium opens adjacent voltage-gated sodium channels, and then it closes them, and then it opens the potassium channels, and then it closes them, and we get depolarization, repolarization, hyperpolarization, return to resting membrane potential. Yeah? But all of that is dependent upon the summation at the trigger zone in this case, and the generation of this action potential. So in sensory neurons, on the other side of this trigger zone, what we've got is all these free nerve endings. So we're going to make them a bit fatter this time. And this is like really the equivalent when we drew the soma before. But this is free nerve endings. Remember, it's afferent. This is where it all starts. Now, we've talked a bit about TRP channels. There are lots of TRP channels. Some of them allow an influx of sodium, some allow an influx of calcium, but the upshot's going to be the same. You're going to get an EPSP because they're both cations. TRP channels, there are hundreds, and we're still finding more and more and more. And what they do is they respond to different things. So this is, remember we talked about polymodal. These free nerve endings can be polymodal. They can respond to chemicals, they can respond to mechanical events, or even thermal events. So TRP channels can be chemosensitive, mechanosensitive, or thermosensitive. And thermo includes hot and cold. So we've got TRP channels. So let's put some of those in. So here's a little sodium channel, and we're going to put a little receptor on it because it's chemically sensitive. Here's another TRP channel, and it has a little voltage sensor because it's thermosensitive. Or we have them, if you remember, do you remember the mechanosensitive channels? Basically, really simple structure, and if you sit on it or you stretch it, you open the channel. So we can have some mechanosensitive that we can just pull apart. And they can be sodium channels, or they could be calcium channels. When they're stimulated, what we get, because they're specific to one particular cation, we get an influx, in this case, of sodium. So we'll have an influx in this one of sodium. And we'll have an influx in this one of calcium. What we're going to get is multiple EPSPs. So here's a calcium generated EPSP. Here's a sodium generated EPSP and another one. And if you remember, just like the soma, all of this is going to start to diffuse down towards those voltage sensors. We activate enough of them, the voltage sensors reach threshold, and those channels open, and we get our flood of sodium into the axon. And that is basically transduction. As always, other channels are available. So there's two others that I want to introduce to you that we'll come back to, particularly in terms of ischemia. One is a purinergic receptor, alpha receptor. Purinergic receptors, they respond, they bind, they're chemically gated if you like, and they bind either ADP or ATP, or even pure and simple basic adenosine. Any of those. So purinergic receptors basically bind adenosine and its progression to ATP. And when we talk about particular conditions, we'll talk about why there's ATP available to bind. Other channels that we need to talk about are called A6. This stands for acid sensing ion channels. And these basically bind protons. Remember old H+, the protons bind, opens the channel. So these are really our three main types of channels involved in transduction. But just remember, TRPs can be chemically sensitive, mechanically sensitive, or thermosensitive. So any of those could cause an EPSP, which will cause an action potential in the primary afferent neuron.
As we went through in the video before, this action potential, once it's generated, is transmitted via the primary afferent to the dorsal horn. Here it's synapses with a second order afferent. The second order afferent neuron then ascends on the other side via the spinothalamic tract or via spino-reticular tract, a different parallel tract, up to the thalamus. At the thalamus it synapses with a third order or tertiary afferent neuron to ascend to the sensory cortex. Different areas of the cortex receive action potentials from different areas of the body. Do you remember the homunculus? So more sensitive, highly innervated areas of the body, such as the lips or hands, require more of the somatosensory cortex than others, hence the homunculus. Via the spino-reticular and the spinothalamic tracts, branches to the pons, medulla, hypothalamus and limbic system also receive action potentials as part of the pain pathway. This then causes an emotional response and activates the sympathetic nervous system. The sympathetic nervous system, of course, raises heart rate, increases stroke volume by increasing contractility, and causes vasoconstriction. Hence, with pain, there is an increase in heart rate and blood pressure. A delta fibers are myelinated. Remember saltatory conduction? Because the action potential skips from node of Ranvier to node of Ranvier, the transmission is much faster. The perceived pain is therefore sharp or stabbing. C fibres, on the other hand, are not myelinated, so transmission is slow. The action potential has to progress along the membrane from channel to channel, threshold, opening each sodium channel, closure at depolarization, opening of potassium channels, etc. It's much slower, so the pain is perceived as dull or achy. C fibres also cause neurogenic inflammation and stimulate their own sensitization to worsen or prolong the pain. But we'll talk about this more in part 2. So at the dorsal horn, including any little interneurons, and at the thalamus, the main excitatory neurotransmitter is glutamate, because they're within the central nervous system. There are 2 types of ionotropic, so no second messengers involved, receptors, and they have their associated cation channels. Although A delta fibres, they only have the fast AMPA type. C fibres have AMPAs and NUMDAs. And really don't ask what these stand for, you don't need to know. Just be reassured that the R stands for receptor. AMPAs are associated with straightforward chemically gated sodium channels, although they can be adapted, and we'll talk more about this in part 2. NUMDAs are actually voltage and chemically gated, so they need a combination of strong local depolarization from the AMPAs, and they need glycine to bind in addition to glutamate before their non-selective cation channel will open. Glycine, by the way, is an amino acid, and it's found just floating around in the synaptic cleft. To open the channels, magnesium has to be removed from the channel because normally it blocks it and it keeps it closed. NUMDA channels, when they're open, allow the influx of both calcium and sodium. They also stay open longer than AMPA channels.
So let's talk about those central nervous system synapses. Just bear in mind that, of course, all the synapses we're talking about, because the dorsal horn is in the spine, it's in the central nervous system, are within the central nervous system. So we're talking about synapses at the dorsal horn, we're talking about synapse in the thalamus, and we're talking about then that progressing on. But if you remember, we've also talked about branches. So we have branches off the second order and the third order, and they have synapses too. So all of those synapses, as we've said, the neurotransmitter, the excitatory neurotransmitter in these cases is glutamate. And glutamate has, on postsynaptic membranes, it has multiple places where it can bind. We're talking primarily, at this point anyway, about the ionotropic receptors. You remember ionotropic, metabotropic. Ionotropic is about where a neurotransmitter binds and it simply opens a channel. Metabotropic is about second messengers, and we'll talk a little bit about those later. Not too much, don't worry. But ionotropic, we have 2. In C fibres only, we have 2 ionotropic channels, or receptors associated with channels. In A delta, we only have 1, and that's the simplest one. And I know I've always said to you, channels are either voltage gated or chemically gated. In this case, I'm afraid we're going to come across one that is both voltage gated and chemically gated. Okay. So we have basically our postsynaptic membrane. I'm going to have to leave a massive synaptic gap here, I'm afraid, because we need to put a lot into it. Okay, so here we have our postsynaptic neuron, and here we have our presynaptic neuron. Okay, so as we said, glutamate is our neurotransmitter. So glutamate, in the usual way, action potential comes along, opens voltage-gated calcium channels, exocytosis, in this case of glutamate. So let's have some vesicles. There's our vesicles, and of course, there's our exocytosis, and we'll have some molecules of glutamate. There we go. Diffusing out into our synaptic cleft. This is our synaptic cleft. Okay, on the postsynaptic membrane, in A delta and C fibers, we have AMPAs. So we have channels with a receptor for glutamate. And this is an AMPA. R is for receptor. As I said before, the AMPA you don't want to know, really. This is quite an acceptable abbreviation. We're going to stick with this one. So this is our AMPA channel. And this is the channel that is mainly responsible for creating EPSPs in our postsynaptic neuron and transmitting that action potential. So, AMPA channels, when glutamate binds, there's glutamate binding diffused across the synaptic cleft, our AMPA channel opens, and we get an influx, as you'd expect, of sodium, which gives us local depolarization, in other words, an EPSP. In C fibers, though, we have another one. The AMPAs, they open very quickly, they don't stay open very long, but they do create EPSPs, and really, they're just like our sodium channels before that we talked about with acetylcholine binding or the rest of it at this point. But on our postsynaptic membrane in C fibers, not in A delta, we also have another ionotropic channel and receptors. I say receptors because we actually need two things to bind. And these are our, I need to put a little space in there. You'll see why in a minute. These are NMDAs. Again, R for receptor, the rest of it you really don't want to know. NMDA is fine. Okay, now these channels, they take a bit more to open. Not only do they have binding sites for two different chemicals, so they're chemically gated, they also have a voltage sensor on the inside. So not only are they chemically gated, they're also voltage gated. Now, what they actually need, so glutamate, we'll start with glutamate. Glutamate comes along, glutamate binds in the same way as it does to the AMPAs. But what it also needs is two other things. It needs that depolarization from the AMPAs to hit the voltage sensor, so the voltage sensor reaches threshold. And it's got quite a high threshold, so it needs strong depolarization from the AMPAs before it will do anything. Yes? So strong depolarization, glutamate binding, And one other thing, it needs something called glycine to bind to. So here's, oops, glycine. That's a rubbish pen, isn't it? God, me and my pens, eh? Let's have a different green. Glycine. Glycine is just an amino acid. It's an amino acid. It floats around the synaptic cleft. It's got nothing better to do. So when all of these things happen, it also binds. So we've got glutamate binding, glycine binding, depolarization within the postsynaptic neuron. When that happens, the NUMDARs open, and they're really cool. We've always talked about channels. Yeah, they just change shape and they open. NUMDARs, when they're closed, they're blocked by magnesium. So we have magnesium blocking the channel usually. Oops. Mg++. Magnesium is a double cation, a bit like calcium, or iron for that matter. When we get both glutamate binding, glycine binding, depolarization via the AMPAs, magnesium comes out of the channel and opens the channel. Once it's opened the channel, so let's get rid of magnesium, off it goes into the distance. Once it opens the channel, the NUMDARs, they also influx sodium. So we'll have some sodium going in. But not only sodium, they also allow the influx of, blue pen, it's got to be calcium. Calcium. So you can imagine, of course, we've got sodium going in. This is adding to the strength of transmission across this synapse. But we've also got calcium going in, which is a double cation, so even more positive as well. So in minimal stimulation, an AMPA will open, we'll get an EPSP because we've got an influx of sodium. In stronger depolarization, stronger stimulation, we'll get these NUMDARs opening in C fibers that allows an influx of sodium and calcium. And it strengthens that EPSP. So there is more likely to be an action potential in that postsynaptic neuron. And later we'll also talk about the other effects of calcium in terms of signaling and synaptic plasticity.
Branches from the thalamus to the limbic system have been heavily implicated in pain perception. In particular, the anterior cingulate cortex of the limbic system, or the ACC, resulting in emotional responses to pain. However, most of the models are pretty theoretical regarding the relevant inputs and also in terms of the feelings, actions, or physical impact. In the diagram, the central neuromatrix includes sensory input, the S, i.e. this is from nociceptors, cognitive aspects related to beliefs and prior experience, the C, and also affective, the A, and this is input related to emotions. The cognitive prefrontal cortex is also implicated in this. Outputs relate to pain perception, it relates to behavior, and also to stress regulation. Another model focused on our learnt experiences in deciding the danger associated with pain. In this model, there's also an intimation that pain can affect us immunologically and hormonally. Please see the VLE or the link for a clear but comprehensive discussion of Lorimer Moseley.
So, okay, in summary, we've looked at the pain pathway. So we looked at, if you remember, transduction, which was about those free nerve endings, generation, and action potential. Off we go again. So remember, we've got TRP channels of various kinds, chemosensitive, mechanosensitive, thermosensitive. If it's a polymodal nociceptor, we've also got our ASICs that bind protons, and we've also got our purinergic receptors that bind adenosine or ATP. Those create EPSPs that are then summated at the trigger zone, and this may then generate an action potential that goes up via the soma in the dorsal root ganglion and into our dorsal horn. So here's our dorsal horn, there we go. So it goes into our dorsal horn, synapses with a second order afferent neuron, which crosses over, goes up the spinothalamic tract to the thalamus. There's our thalamus. Third order goes on to our somatosensory cortex. Now remember, we also have branches. So we have little branches here that potentially go to our old friend, the medulla. Also, our old friend, the hypothalamus. And the rest of the limbic system. Remember, the hypothalamus lives within the limbic system. So we've got multiple branches going off here. Up here, we've got our sensory cortex. So here's our thalamus. This is our precortical relay point. Here's our sensory cortex. And you'll notice I've done slightly different colours, because basically what we're talking about in terms of the green is transduction. The next phase in our lovely turquoise is transmission. And up here, that I'm going to circle in pretty pink, is perception. So not only do we get perception up in the sensory cortex that tells us we've got pain, if you remember these branches going to the limbic system, we also get the influence of previous experience, and the memories of this pain start to get stored. So they're also involved in perception. Of course, in terms of the medulla as well, we're also talking about sympathetic nervous system activation. If we get sympathetic nervous system activation, here we go. You remember what the sympathetic nervous system does? It increases heart rate, increases respiration, increases cardiac output, makes us sweat. So lots of different physical signs of pain if it's activated. So this is basically our pain pathway. Within that pain pathway, we also talked about the fibers, didn't we? So we've talked about two main fibres. Our C fibres, and if you remember our C fibres, these are our unmyelinated fibres. Therefore, our poor little action potential has to go from channel to channel to channel to channel to channel. Therefore, they're slow. Because they're slow, C fibres, when they're activated, give us that diffuse, dull, achy pain. So we get an ache. Our other fibres that we talked about are A delta. Don't expect me to draw the symbol for delta. These, of course, are myelinated. And you'll see in text that they're thinly myelinated, but they're still myelinated, which makes them faster, much faster conduction speed. Saltatory conduction, remember, skip from node of Ranvier to node of Ranvier, much faster. So they're fast in comparison. And these give us the stabbing type of pain, stabbing or burning pain. So if you activate these, you get stabbing pain. So we talked about fibres. We also talked about the central nervous system synapses, and we talked about two types of channels. So we talked about AMPAs. Now, AMPAs, if you remember, they allow an influx of sodium. They open rapidly, they close rapidly, and we get a sodium influx. And they are our main cause of transmission of our action potential across those central nervous system synapses. But we also talked about, in C fibres only, oops, get rid of that, oops, NUMDARs. And if you remember, these were our ones that need three different things to open. So they need depolarization from the AMPAs, because they have voltage sensors, but they also need glutamate and glycine to bind. And as a result of that, not only do we get sodium influx, so here we've got sodium influx, we get sodium influx, and we get calcium influx through the NUMDARs. So they strengthen the action potential, they strengthen the EPSPs, but they need quite strong depolarization from the AMPAs to open. And when they do, we get an influx of both sodium and calcium. But remember, A delta fibres don't have NUMDARs, or not that we found so far. Okay, so we also talked about, see up here, we talked a bit about perception. And I've pointed out here, I've got one nice, simple little branch going off. But actually, recent research that's come out has sort of given a different picture. And it was a picture as well. It's quite interesting. So we've got, that's absolutely going to be a rubbish brain, but there's our brain. We've got our brain. We've got an action potential coming in, up to the thalamus, da-di-da-di-da. Little branches off to the medulla, limbic system. We've also got the frontal cortex that we know it goes to. And actually, the picture is really more a case of that. All that input of pain is now thought to have massive different branches. Remember, interneurons, pyramidal neurons, multiple millions and millions of synapses. It goes everywhere. So it has a much greater impact than just we can simply draw with one branch.